patient is a 73 years old female with a shift complaint of shortness of breath. 1 month prior to admission, the patient experienced progressive fatigue and mild dyspnea, no chest pain initially. She found a progressive enlarging 1 centimeter mass at the previous left mastectomy site. The patient was evaluated at other hospital with diagnosis of breast cancer with suspected pulmonary metastasis and left pleural effusion. She was performed a thoracostomy drainage, and during the resulted bloody fluid. The patient was discharged after 10 days hospitalization. 1 week prior to admission, her dyspnea worsened. She developed a new onset retrosternal and interscapular chest pain. The left chest wall mass enlarged rapidly and now measuring approximately about 7 by 7 centimeter, associated with erythema and warmth. The patient admitted to our hospital for further evaluation. During her disease course, no cough or fever were noted, but she complained that she had a significant weight loss for about 6 kilometers over 2 months. Her past medical history, she undergone a lab breast tumor surgery for about 1.5 years ago with unknown histopathology and procedure. On examination, she was alert, well-oriented, with normal body size. On pulmonary examination, she appeared decreased breast cells donated to percussion and decreased tactile freeness over the lower two per third left lung. And also, we can find 7 centimeter firm mass on the left breast. On imaging, breast ultrasound showed that a hypoechoic mass measuring approximately 10 by 7 by 5.5 centimeter with well-defined margins and a lobulated border. Multiple lymph nodes can be found in the left axilla, but reserve tachyhelium. So we assess that the breast lesion is bilateral. Chest X-ray. We can see a right trachea. A right trachea deviation, partial left lung collapse, widening the mediastinum at the level of aortic arch, shifted to the right, and increased opacity in the left chest region, obscuring the cardiac border, and pleural effusion, and the increased opacity in the left regions cannot suspected. For the first one, a lesion originates from the chest wall overlapping the cardiac ciliate. The second one is an intrapulmonary lesion overlapping the cardiac ciliate, and the third one is a mediastinal lesion. We can see that descending aorta machines cannot clearly visualize.
Can we go back to the X-ray? What do you think about the left upper lobe that has air in it? Normal or not? Yeah.
Yeah, I think it's just decrease the volume of the lung, the left lung, because of pleural effusion. Can we go on? The laboratory test showed that there was an increase in the CRP index. And pleural fluid test unit that it was exudate microbiology culture positive with Proteus mirabilis.
Do you believe that was a real organism, or someone didn't wash their hands very well? In England, it would never be Proteus as a plural infection, but maybe it is in Vietnam, I don't know.
Because that the inflammatory index of CRP has increased, so I think it could be right result.
6 is very low for a CRP, isn't it?
Yeah.
What is the upper limit of normal for CRP in Vietnam?
5.
5. And it was 2.5, okay. In my experience, if you have a big pleural effusion like that, which is an empyema, the CRP will be very high. The only time it is not very high is in TB. TB CRP is normally 100.
Don't you think that in immunosuppressed patient, the CRP cannot be
Possible, but she is not immunosuppressed.
She has a breast tumor before. She could have received some chemotherapy or something like that. She can be an immunosuppressed patient.
Yeah. Did you say her white blood cell count is normal? She is not neutropenic. Is that normal? I think it's normal.
It's normal.
Yeah.
So at that time, she had 3 issues. The first one is massive left pleural effusion. The second one is mediastinal widening right deviation. The third one is left breast mark classified as BRAF4, showing an increased size with history of surgery for left breast tumor. So the patient underwent a CT scan. Sagittal will
Can I see the axial view again, please? Yeah, difficult. Okay, cool.
Yeah, on CT scan, we can see a mass lesion in the left thoracic cavity measuring about 7.4 by 8.7 by 8.7 centimeter with a lobulated border, ill-defined margins, and a poor contrast enhancement with heterogeneous density, maybe with necrotic component inside, no fatty components, as well as calcification. In addition, there is small amount of pericardial effusion and some lymph node in the mediastinum, which are regular borders. So the related structure to the lesion is the left upper lung lobe, left pleura, left pleural, left upper lung lobe, and the anterior mediastinum. And it invaded into pericardium, also to the maybe to the left pleura, the pulmonary trunk, the left pulmonary vein, the left upper pulmonary vein, and the left chest wall here. But we don't know if it had invaded into the left atrial appendage or not, and the superior aortic recess. Should we go next?
Yeah. Interesting.
So, to define the nature of the lesion, it can be primary or secondary, because we haven't known that the origin of the lesion. So we think it can be a left upper pleural tumor, or upper lung lobe tumor, or it can be an anterior mediastinal tumor. Or if it is a secondary, it may metastasis from the breast tumor. If it is an anterior mediastinal tumor, it can be a fluid lesion because of its density. So the possibilities, I think that the first one, the most likely one, is a breast tumor metastasis to the left thoracic tumor. But I think we cannot exclude the possibilities such as the first one, anterior mediastinal tumor, accompanied with breast tumor. The second one is a pleural or a lung tumor, accompanied with a breast tumor. So at that time, my question is, what is the next step?
Can you go back to show the left upper pulmonary vein on the CT? Yeah, perfect. I think you are right that it is a lung tumor, because if it was a pleural tumor, it will compress the lung, and so the normal vascular structures in the lung should be compressed posteriorly. If it is a mass eroding through the lung, then it just erodes and gets to the vein eventually. Do you see what I mean? If I were to, a pleural tumor would be like a pneumothorax, the lung would collapse and the vessels would move backwards. So I think you're right, I think it's in the lung. The other possibility with breast is that the lymphatic drainage of the breast is that the medial 10% of each breast drains to the internal mammary nodes. I was wondering whether this was a big mammary nodal metastasis, but you can see there is still lots of extrapleural fat. So I don't think it's extrapleural, I think it's a lung metastasis, I think. Does that make sense? Did you say it had calcification in it? Does the lung mass have calcium in it? Calcification? No. Okay.
So, and another question is, do we need to clarify the lesion before any treatment plan? How? By MRI or biopsy?
Ask everyone, what would you look for on MRI that would help you here? Anyone? I can't think of anything. I think we just need to biopsy this and find out what it is, I think. On MRI, it is not a very good test, but if you do dynamic MRI, you can see whether the lesion moves along the pleura or is really invading the mediastinum, is attached to the mediastinal structures. Occasionally that can help a surgeon decide whether they can resect the mass or not, but we do not do that very often, and we already know there is a breast abnormality, so whatever this is going to be inoperable. So I don't think MR, I think biopsy, but I like biopsies. What did you think?
Yeah, I also think we can perform a biopsy to verify what the lesion is before any treatment plan.
Yeah?
Yeah.
Thank you.
So our hospital treatment plan are left breast mastectomy and exploratory thoracotomy for thoracic tumor. And the pathology turned out that the breast tumor was a malignant thyroid tumor, no metastasis in the 5 left axillary lymph node. And the thoracic tumor was metastasis from the breast tumor.
Phylloides tumor.
Yeah.
Cool.
So that's the end of my case. But I have one question about the location of the lesion.
Yeah.
Yeah, we can see that the center of the lesion was not in the lung, was mostly in the anterior. Yes.
No, so the lateral border of the mediastinum is the mediastinal pleural. So the anterior mediastinum ends about here. But if you were to put a mark in the center of it, symmetrically it would be bang in the center of the lung. Anterior mediastinal tumor should be arising here. It is too far to one side. Can I show you a case of phylloides tumor?
But I have another question.
Oh yeah, go.
Yeah. As I told you at the lunch,
Yeah.
I have seen a lot of cases that the lesion was located here, next to the left lower,
Yeah.
and mostly in the anterior mediastinum. So how can we distinguish?
How can we distinguish where the lesion is?
Yeah.
Difficult, maybe it doesn't matter so much, but if it has mediastinal fat around it, then we can guess. More commonly, it starts in the mediastinum and then grows everywhere. And then you do not know if it is from the anterior mediastinum and has spread, or from the lung and has spread into the anterior mediastinum. However, it is very rare for a lung cancer to invade the anterior mediastinum. All the drainage and lymphatics go to the hilum, not the mediastinum. So if you have a big mass in the anterior mediastinum and lung, it is much more likely to have started in the anterior mediastinum.
But my question is just one lesion only in this area, next to the left lower.
Okay.
But, and mostly in the anterior mediastinum. So how can we distinguish that lesion belong to the left pleura or the anterior mediastinum?
Oh, I see.
Yeah.
Often, pleural lesions grow along the pleura, so they will be longer front to back than side to side. That is not true for anterior mediastinal lesions. They are more likely to be round. Primary pleural malignancies are very rare. Mesothelioma, we have a lot in the UK, will very often be multiple places of pleural thickening, and it will be thick along all the mediastinal pleura, not just one focus, not just one area. The other thing is that if you have a bad thymoma, a high-grade thymoma, they always metastases to the pleura. So you can have both. So if you have an anterior mediastinal nodule and pleural nodules, it will almost certainly be a thymoma, metastatic thymoma. Metastases to the pleura are more difficult to know, anterior mediastinum or pleura, but that doesn't matter too much. All that it matters is it's metastatic.
In this case, can we use the acute angle to locate the lesion?
That is possible, but there is also a pleural effusion here, and the mass is fluid density, so it is difficult to know where the pleural effusion ends and the mass begins. But just looking at that slice, you would guess it is, let's have a think. Yeah, you would, this bit looks like it's in the pleural space because it makes a shallow angle. A lung mass should make that angle with the lung, but this has invaded the pleura, so by now there will be abnormal pleura as well. So if it's very advanced, it's less useful. Does that make sense?
Yes. I think we have this question.
Yeah.
Yeah, my question is, does the lesion has invaded into the left atrial appendage?
Yeah, difficult. I don't know. I don't know.
Yeah.
I think it's important to report whether this is tumour thrombus in the arterial system or heart, or bland thrombus. Has it caused just a clot with no tumour in it? Because you would anticoagulate the second one, but you would probably not anticoagulate the first one. I don't know, depends what you do locally. Here it will be tumour thrombus, not bland thrombus, because when the atrial appendage thromboses, it will always thrombose the whole thing very quickly. So I think it's tumour, but I don't know if it's in the appendage or not.
Should we just report that the lesion has contacted the atrial appendage for
Yes.
to alert the surgeon?
And I do not think we are very good, anyone is very good at knowing whether it has invaded or not. The pericardial effusion is very often a sign of pericardial invasion. So if there is a big pericardial effusion, lots of people have tiny pericardial effusions. If there is a big pericardial effusion, you will say it has invaded the pericardium. That's clear. But for example, the pulmonary trunk on the earlier slices, very difficult to know for sure. Easier if you have old imaging and you know where the mediastinum was before, but it is very difficult often. I think you're right. I think it is invaded the mediastinum, has to have invaded the mediastinum where your arrow is. It's bulging in. The mediastinal border should be straight there. So you are right, but in general it is very difficult.
So what about the superior aortic recess? You think it has invaded that recess?
I think so, because you very often, have you heard of the bikini sign? It's not very common, but if you have a triangle of fluid in your superior pericardial recess, it is normally a sign that you have pulmonary hypertension, often. This has not got a straight line, it has a bumpy line. So I think that is tumour, because normally the recess is very smooth and straight. So I think you're right. Can I show you a case?
Yeah, I love
It's going to scare you. Yeah, please.
First of all, I think the primary diagnosis from the radiologist field is the metastasis from the breast tumor. However, in that case, do we need to differentiate the origin of the tumor? That's the pleural origin, or the lung, or the anterior mediastinum. I think it's the metastasis, and from the radiologist field, could you differentiate the origin and what is happening in this case?
I think in England anyway, our job as radiologists is to send the patient to the right specialist as soon as possible. Lots of cancers do worse if the patient goes to see the wrong surgeon or oncologist first. I think we have a job to have our best guess where the primary is, to send it to the right team to do the investigation and management. Pleural metastases are much more common in breast cancer than other cancers. So I would want to know if there are pleural metastases, because it would make me much more likely to send the patient to the breast team for investigation. But I agree, once you know the diagnosis, I can't think of a reason why it would matter. Although, in England, if you have metastatic breast cancer, until very recently, you never had surgery. If you had one lung metastasis, they would not operate. Nowadays, they are starting to operate to see if it has a benefit. So if this were lung and operable, then I would want to be certain it was in the lung, not in the mediastinum or pleura, because the pleura would not be operable, and if it was anterior mediastinum, it would be a different surgical approach. But that's very new in England, and it can only oligometastatic, one site of lung metastasis from breast, they might chop it out now in a trial. Does that make sense? For this case, it is so advanced, it has to be chemoradiotherapy, and I don't think it matters too much, I think.
Thank you.
This is a lady, this is a scan from 2020. Let me see if I've got it right. Yes. So CT scan, no contrast, we never give contrast. She has had a previous left breast cancer and a prosthesis. Can you see she also has a calcified lung nodule? Yeah? Calcified lung nodules are always benign. Is that true? I messed it up. Are calcified lung nodules always benign? No, definitely not. Why not? I'm a bit deaf, you have to speak up.
Depends on the type
I've messed this up, sorry. Here we go. It depends on, oh my God. Oh dear. Okay. Depends on the type of calcification. Yeah, tell me more. Yeah, true. So some sorts of calcification are very likely benign, popcorn calcification. And in lymph nodes, in sarcoidosis, you get something called icing sugar calcification. I guess it would look like if you dusted flour very gently on the lymph nodes. It has increased density, but within that it has lots of tiny little dots. That is sarcoidosis, and it will be benign. If the calcification is central, it is much more likely to be benign, but you can never exclude that there is not a lung cancer growing around a calcified granuloma. Separately, squamous cell cancers can produce calcium before treatment. So calcification in a big lung mass can always be a squamous cell cancer, especially if it is not straight in the center. Could be in the center, but it is unlikely. The other metastasis we have seen today is an osteosarcoma. which produces calcium. This lady's breast cancer was a phylloides tumour. Guess what that calcified nodule looked like 3 years later? It is not good news. So calcification, and I got it. We always biopsy, always biopsy. So don't forget, my final teaching point is that you of course need a history, but be very careful if you have just a calcified nodule with almost no soft tissue. If the patient has a history of osteosarcoma or phylloides tumour, you need to follow it up very carefully. Looks different from yours though, doesn't it? This is very calcified, and yours was not. Phylloides tumour, when they metastasize on histopathology, look like sarcomas. They transform into sarcoma-like processes, which is why it has calcified. I am not a pathologist, so I can't answer any more questions on that. This is yours is only the second case I've ever seen, and this was the first case, so I have no idea. I think it's 50-50. Yeah. So thank you, I've now seen my second case. I'm very grateful. Yeah, not always true. Not always true. And in fact, there are some sorts of testicular cancer where you get metastases and the primary malignancy disappears, Morgagni lesion. I agree that if you have one metastasis, it is much likely to be bigger than if you have many metastases, but that is because people with many metastases die before they can all get bigger. Does that make sense? So one metastasis has more time to grow before the patient presents, perhaps. CT scan, yeah. It is an evidence-free zone. For lung nodules, we use the British Thoracic Society guidelines, but they are for non-calcified lung nodules. 3 months, 1 year, and 2 years, but you can stop at 1 year if you can measure the volume of the nodule and it has not grown by more than 25%. So if it is stable on volume, you can then discharge. It does not apply to calcified nodules, and it does not apply to patients who have had malignancy, because malignancy metastases can be very slow growing. So I would say, I think you would always want to do a 3-month CT, because if something is very rapidly growing, you will know at 3 months, and then once per year, I think.
And the only thing is not contrast CT.
It is much quicker to scan a patient without contrast. You do not need to wait for their bloods. The radiographer does not need to cannulate, and it is quicker on the scanner. So we can do lots and lots and lots. And also, if you have thoracic radiologists reporting your scans, you do not need a contrast to see lymph nodes. We can see them without contrast because we are very boring and it is all we look at. No ultrasound, not much MRI, chest CT, chest CT, chest CT, chest CT. Our surgeons after a patient has had lung cancer and it has been operated on, our surgeons do not want us to give contrast. Well, patients have a scan every year for 5 years to make sure that cancer does not recur. Our surgeons do not want those patients to have contrast because they are quite frail and they are worried about the patient's kidney function. We're okay with that. Cool. Thank you very much. Brilliant. 2 cases. Thank you very much. I really enjoyed it.